So tonight is supposed to be for review and counseling. However, we would like to focus this section dedicated to review what you have learned so far, especially the opening, welcoming the patient, opening rapport to the patient, as well as closing, how to conclude a visit. For now, we conclude the questioning, the interview, but try to do it the way that people feel well informed, leave them time to raise questions, summarize what you've been discussing so far. So today we're going to practice those things. And Dr. Hung Bo will also introduce you the way we do over here in the US, how to evaluate the performance of a student, the doctor in training. We will use this way to evaluate you in the future to ensure you meet our standard for the certificate by the end of the class. So pay attention, and hopefully this gives you an idea what we require you throughout this class, and in the way you can compare yourself to your peer in the US. If they can do it, so can you. So without further ado, I leave it to Dr. Hung Bo to start the section tonight. Yeah.
Thank you, Edmund. Sorry about that. So I think welcome everyone. So this section is mainly just to review what you guys have done so far, I think for the past 5 weeks. Obviously, there's a lot to go through because, medical students, they have 4 years to practice this. And even in residency, we still do this. And even an attendant, you're still learning how to interact with patients. So it's not necessary that, you have to know everything, but this is the guideline that we go by and what they expect you as a medical student, as a medical doctor, and a resident. So I think we all should know a little bit about it. So for the agenda today, I'd like to review the OSCE structure. And then after that, you guys are going to practice with the TAs, and then you'll be evaluated with a checklist of items that they will be, looking through. And I'll show you just a quick view of that checklist, but don't be overwhelmed about all the things that you have to be, require on that checklist. So does anyone know what is OSCE stands for? Because, we use it all the time, but like, what does it stand for? Anyone can raise your hand and, answer that. Okay, so I guess, this is probably new for you guys because it's used in the United States. So I don't know in Vietnam if they use the same thing, but OSCE is basically, it's a standardized sort of a clinical examination. It's objective, structured clinical examination. And why do they have this? The reason is because, we have a lot of medical schools across the country, and they like to evaluate the students all across the country the same way to make sure that, everyone is being examined the same standard test. So this is being used in medical school. It's all used in, in clinical examination, like the step 2 CES. So I think for those who want to take the exam, you probably had to learn about the OSCE structure. Same thing for residency. Even after you graduated medical school, even when you go to residency, you still have to do some of this OSCE occasionally. So what is OSCE structure? So obviously, first you're going to have the opening, and then we'll go through each one of these. But this is a quick overview. So when you go into the exam room, the first thing you do is the opening. So it's basically mean that, you quickly make a connection with the patient, you build a rapport with them, just kind of get to know them a little bit, face to face, and then you go into the obtaining the medical history. And this is when we go deep into the old card system and all the things that you have to ask the patient. And then in the real exam, you have to perform a physical exam, either that a focused physical exam or it's a generalized physical exam. And then after you get the physical exam, you have to be in the exam room, and then you have to sort of go to the counseling and deliver the information, what you think the patient have, what would be the treatment for the patient, and sort of go into the detail. And then at the end is basically closing. Closing means that you kind of summarize, what the patient have, what are their concerns, and what is, what you guys have been discussing about. And obviously you need some time so that the patient can ask you questions and you can answer them, at the end. So for today, I think we've focused mainly on the opening, obtaining the medical history. We're not going to go to the physical examination. I think the counseling and deliver information will go to at the end. That's when you get a little bit more of the medical knowledge. That's when you start sort of understanding what you should tell the patient and counseling them. And then the closing is mainly just basically a quick summarize of what you guys, what the patient told you. And I think for that, I actually have a quick like exercise homework for you at the end that you can, post online, and we can sort of, look at the video, see how you guys do, but that's for later. So the opening instruction. Obviously, sometimes the patient, you've seen them before, but obviously sometimes you haven't seen the patient before, and this is the first time that you're meeting them. So in the U.S., before you meet any patient, the requirement is that you have to wash your hands. So near the door before you go into the room, they always have a hand sanitizer. Especially with COVID, patients are very self-conscious about you washing your hands or sanitize your hand before, shaking the hand. Before COVID, we don't even shake hands anymore. But now, since COVID has kind of died out a little bit, we start, shaking hand with patient again. So we really have to pay attention that really need to wash your hands before you see the patient. And then after that, you have to introduce yourself because, in the hospital, there's so many doctors, there's so many clinical staff, and sometimes patients don't know who you are. You could be a nurse, you could be a CNA, you could be a pharmacist. So it's very critical that you walk in and then you introduce yourself so that the patient know who you are. So for example, if I walk into a patient room, I say, hi, my name is Dr. Vo, and I'm a rheumatology fellow, and, very nice meeting you. So they know who I am and, what is my role, and then you can proceed to the next thing. And then after that, you ask for permission, okay? Not everyone's gonna be happy seeing you because some of the large hospitals, they have trainees, right? So they have medical students, they have fellows like me, and then they have the attendant. Not every patient, come to a meeting and they want to meet a medical student first. They want to see the attendant because maybe they have something they want to talk to the doctor, the attendant doctor, not to the medical student or to you. So you have to ask them, is it okay that I talk to you first? Okay. So you can say, I work with Dr. So-and-so. Is it okay if I talk to you first? And then, the attendant's going to come in and we can talk to each other also. And then you verify the patient. I brought my mom to the hospital before, and people actually don't verify the name, and they just assume that you are Asian, so that you are this Miss X, Win, or Tran, or whatever. So it's really important that you really have to verify the name. So you can ask, are you Miss X? Are you Mr. Y? And then you can also ask, what would you like to be called? Because some people, they can go by the nickname, like if they go by Bob or Bobby or whatever the nickname they like to be called. But you have to ask them. Some people like to be called by the last name only. So you have to respect the patient. Whatever they wish, you have to tell them. And this is very important too, because if you watch a lot of the show, like Layla I, right? There's a lot of transgenders now. So you have to understand that that call into the mix that you have to know how to address a lot of people, because they could be, a female on paper, but if they transform into a male, then they like to be called something else. So you have to really ask them, like, what would you like to be called as? Okay. So that's very important nowadays, especially with the movement of all the LGBT communities. You have to respect them. And then the next thing is sometimes patients come with their family members, like their wife, their husband. So you have to ask, like, who's in the room with you? Is it okay for them to be there? Okay, because let's say if, you know, they come there with their significant one, like their girlfriend or the boyfriend, but they don't want them to be there, they don't want, you know, to share the, you know, the private information, then, you know, you probably would like to ask the boyfriend to step out, or, you know, somebody to step out if the patient doesn't want that person to be there. Okay. Most of the time they don't, because there's a reason why they brought their loved one into the room with you. Just make sure you acknowledge that person also. So that is basically the opening, the introduction. So it's a quick, you know, wash your hands, introduce yourself, ask the patient for permission to talk to them, and then ask who they are, and then you can start the visit. Okay. So the very first thing that patient will come in, what we call is a chief complaint. So sometimes we write abbreviation is CC on the paper. So that's a chief complaint. So what exactly the patient is coming in today for? For example, you know, you can ask them, what brought you in today? All right. So how can I help you today? So what brought you to the hospital or clinic today? Okay. Some people are there for urgent visit. They have some pain, or they could be there just for their regular, you know, follow-up visit, or they just there for their annual physical examination. Okay. So this is the MT rubric that a lot of the medical students are very familiar with. So this is basically what we call an H&P, so history and physical. So you fill out these things whenever you see a patient. This is basically what will you write to see when you see a new patient or you admit a new patient. So the first part is a chief complaint of the reason for the consult. And then the next thing is the history of present illness. Okay, so this is what expected of you as a, you know, a learner or attendant or whoever you are. So you have to know what is going on with the patient, and, you know, what brought them in, and then what is the characteristic of the illness or the present illness. So this is the old cards. I think all of you guys are familiar with old cards already. I'm not going to go through it. I think it's better for you to, you know, practice with the TAs for this. But I will talk to you a little bit later on about, you know, when is the old card is relevant? When can it be used? Because not every single complaint that the patient will come in, you can use old cards for, okay, or which we'll go through later. So the old card stands for onset. Okay, so is it an acute, or is it a chronic problem? You know, did it happen just a day ago, a week ago, a month ago, a year ago? You have to know exactly onset. Then the location, all right, where is it? Then duration, how long does it last? And then the characteristic, this is important, okay? Is it a burning sensation? Is it a dull, or is it a sharp pain? You know, what kind of pain is it, okay? So when you ask this type of question, don't ask them like close-ended questions. Don't ask them, is it burning? Is it dull? Just ask them like, what does the pain feel like to you, okay? And then the patient can describe it to you. If they have chest pain, a squeezing chest pain, they'll describe it to you. Like, I feel like there's an elephant sitting on my chest, okay? So there's way to ask questions and you get different answers. So if you ask them, is that you know, what is the pain dull? Then they will answer you yes or no, okay? So if you ask them, you know, how would you describe your pain? Then they will tell you. So there's a little thing about, you know, asking the question, the same thing, but, you know, with different questions, you have different answers. And then you ask them about aggravating factors. What make it worse? You know, relieving factor, what make it better? And then you ask about timing. You know, is it constant? Is it intermittent? And then severity. So everyone know the phases you can use is 0 to 10 scale. You know, 0 is no pain, 10 is the worst pain ever. You know, you can rate what is the pain right now. Okay, so that's the old card. I think you should learn this every time that you go into the patient's room, and you can write it down and you can just remember that. But if you ask them, you know, enough, then you probably know this by heart right now. So this is the second part, the history of present illness. So this, you fill out the second part. And then this is the tips for, you know, obtaining the HPI. Like I say earlier, try to use open-ended questions, okay? So that will really, you know, help you get a lot of answer without asking a lot of questions. For example, if you ask, does it hurt? You know, the patient will say, yeah, it hurts, you know, and then you end up having to ask them more questions. Where does it hurt? You know, how much does it hurt? So instead of asking, does it hurt? The better way to ask is tell me about your pain, okay? So that's an open-ended question. And then the patient will tell you a bunch of things, my pain is here, it's radiate to here. And so they tell you a lot of things. And then you don't have to ask them a lot of questions. You just write down what you need to know. And then you ask them questions that they didn't, they didn't tell you. For example, they didn't tell you the severity, then you can ask about the severity. So that is a way to ask questions. You always use the open-ended question. Try not to use, the yes or no question, okay? And then the second thing is, a lot of time when people ask you questions, they ask you multiple questions at once. And this is problematic for a patient. For example, if I ask you, do you smoke or drink? The patient don't know which one to answer. You mean, do I smoke? Yes, I don't smoke. Do I drink? I don't know. So ask two questions at the same time. The patient don't know which one to answer first. And sometimes they forget which one did you ask first, okay? So instead of asking multiple questions, you can only ask them one question at a time. So you ask them, do you smoke? You wait for them to answer. Do you drink? Then you wait for them to answer, right? But the better way to ask the question is, do you smoke? They're going to say yes or no. But you can use an open-ended question. Like, for example, how often do you smoke, right? Or how often do you drink? And they'll tell you, well, I don't drink. Or they can tell you, well, I drink 2 beers a day, right? Or I was like, I'm just an occasional drinker. So that saves you time instead of asking, do you smoke or you drink? And then you end up have to ask them more, okay, how much do you drink? And you can ask them like, how much do you drink? If they don't drink, they tell you that they don't drink. So that's a tip for asking questions in a way that it saves you time, okay? And the third thing is, especially in the OSCE exam for medical students, you're graded, you're being evaluated for empathy. So the way you show empathy is, for example, if someone is in a lot of pain, when you walk into the room, the first thing is, the person there is going to be like crying in pain. So it's really, really necessary for you to acknowledge that they're in pain. You can tell them, oh, I'm really sorry that you're in so much pain, but, let's talk to each other first to find out why you're in so much pain, okay? So you're like, if someone is in pain, the first thing you come in and go like, hey, like what happened? What's going on? It's not really showing that you're really empathetic for the patient. I mean, in real life, it's different, but, in the clinical sort of context of an examination, they want you to show some empathy for the patient, okay? So if the patient looks sad or worried, you can say, hey, you look sad and worried, tell me what's on your mind. Or if they're in a lot of pain, you can say, I'm really sorry that you're having a lot of pain, but let's work together so that we can figure out what's going on and what's causing your pain, okay? So that's just a little quick tips of like showing empathy. And you are being evaluated for this. So just pay a little attention to that. So this is the next part of the H&P. So the next one is allergy and medication. It's very important because, certain complaints can be caused by medication. So you have to know about the medication. You have to know about what allergies they have. So you can ask them, are you taking a medication right now? It's important to ask, especially for our culture or Asian patient or, other patients who we are take a lot of herbal supplements, right? Like we always have like, a lot of herbs and tea that we just get it from the Chinese, medicine. So really have to tell the doctors about those things. So that's why we have to ask them, because some of them do have, renal toxicity. Some of them have hepatotoxicity. So that's why you have to ask them. And then you ask about allergies. So when you say allergies, be careful because sometimes patients will confuse between seasonal allergies, the one that you go out and you're allergic to the pollen, your eyes are itchy, your eyes are tearing. So that's the seasonal allergy. We don't really need to know that. What we really need to know about medication allergies. So ask them about what allergic reaction you get when you take that medication. Depends, right? If the patient have just a rash, if they take a medication, that's very different from they have anaphylactic shock. So that we have to know what exactly the reaction is. You can't just tell like, oh, they are allergic to aspirin, but you don't know what kind of reaction it is. So those you need to know. And then the next thing is the past medical history. And obviously you need to know about their medical history, search for history. So obviously you can go through all of that. Those are the questions you can ask. Family history. So those are the ways you can ask them, your family have any problem? Are the parents alive? Are they good health? How did your mom or mother die sometimes? And are your brother, sister alive? So that's family history. So don't forget to ask them. So the most important thing that, you'll be tested for is social history, because that is the crux of the social history or the past medical history for them. So make sure you ask about alcohol, okay? Smoking. Now, not only smoking, you have to ask about vaping, because that's a new thing, right? People don't smoke as much anymore. They vape a lot, and they can have side effects too. So that's why you need to ask about vaping. Drugs, so different type of drugs. IV drug use, recreational drug use, that's different, right? That's marijuana, that's pot. And then substance abuse, like opioid, and some, people are addicted to different things. Ask them about their employment. What do they do for work? That's important. Living situation. Who do they live with? They live at home with somebody. They live up on the third floor. Are they homeless? That's very important. And then hobbies. This is very important, especially for teenagers or for kids. This is how you connect with them, right? Ask them about hobbies. Ask them about things that you can connect with them, because obviously, they are not very happy to be in the doctor office. So this is a good way to connect with them. So this is social history. And again, tip for obtaining social history. So you'll be asking a lot of personal questions, especially with teenager, or people who are very sensitive from different culture. You have to make it as normal as possible, because some of the questions, they don't get asked in their own culture or at home. So you really have to make it really normalized. You could just say, hey, we have asked our patient all these questions as part of the exam. So is it okay that I ask you too? Like, are you sexually active, right? Are you having sex with male or female? Those kind of things. So just have a little bit of something before you ask them a very sensitive question that kind of break the ice a little bit, and just telling them that this is a normal thing, okay? Nothing that we do here is personal, okay? And then this is where the opportunity to counsel. Obviously, if you're a medical student, if the patient asks a problem about drinking, you have to counsel them about drinking. You have to counsel them about smoking, but we're not going to go in deep detail about that, because I think right now we're just trying to get the hang of it. And then the closing part. So this is difficult, even for me right now. So the closing part is when you summarize a patient's story. Basically, all the key component history, they will tell you a lot of information, but you have to be able to distill down to the important information without leaving out, like, the important information. And then you have to summarize it. And then you have to ask the patient, did you miss anything, or did they want to add something else? And this leaves them, the ability to, add something else to whatever that you present, okay? So the closing part is very, very difficult, but, we will practice. This is sort of the question that you're supposed to be asking a lot. And obviously, even for me, I will not be able to ask every single thing on this list, but this is basically how they grade you, okay? And as you can see, that's very overwhelming, but once you get used to it, you can ask probably about 60 to 70% of the question in there. So when do we use O cards? The O card, it doesn't work for everything. It works best for pain, because when you think about pain, you can ask them the location, when does it start, when does it, where does it radiate to, what makes it better, what makes it worse, but it doesn't work for everything. So think of some of the complaints that the O card system will not work for. For example, someone have diarrhea. I mean, you will not be able to ask them, like, where is the diarrhea? It's awkward. That you have diarrhea. You have to ask them how many episodes you have diarrhea. What kind of diarrhea? Is there any blood in it? So the question is different. So like I say, the O card is good for certain things, but it doesn't mean that you can use it for everything. Okay. For example, blood in stool. So this is a thing that you have to ask a patient when they have blood in the stool. You cannot use the O card system. That's not relevant for this. So these are the things that you're supposed to ask, right? So what kind of blood is it? Melena? Is it bright red blood? What's the amount? What's the duration? What's the associated symptoms? And then you ask about relevant medical history, medication, and then surgical history, family history. Same thing for in the urine. Okay, so again, O card doesn't work for everything. Okay, so trying to know that it works the best for pain and certain things. So again, this is a structure. I think for now, we're going to focus on the opening and obtaining medical history. That's the two important parts that you're going to be practicing tonight. So after this, I'm going to post on Facebook about this practice is for summarizing. So I'll give you a case with all the questions that you would ask the patient, and then the patient responds to it. And I'd like you to record a video of your presentation. So based on the response, I want you to summarize the case, and then just record yourself, present, and think about you presenting that case to somebody else who doesn't know the patient at all. And then you will post on this website I'm going to use. It's called Notion. That way I can look at the video, and then I can actually comment on it. So it's a lot better than Facebook is. Facebook is a little bit difficult now with all the stuff. So I like this one better because you can actually upload the video. So I will post a link how to do it, and then you put it up there, and then I will I will look at the video, and then I will comment it. Okay. So I will put the instruction on how to do that. All right. I think that's the end of the presentation. So I want to know if anyone have any questions before we move on to practice.
Yeah, I don't have a question. Thank you, Baxi-Hung. I have a couple of comments. Mm-hmm. So can you go to your first, I think, 2 slides on asking someone's name?
Which one?
Yeah, can I ask you your name, like when you ask them their name?
Oh, like this one? Are you Miss X?
Yeah, are you?
Yeah.
Something that we do in the US is we ask, can you tell me your name and date of birth? Many people have the same name. So in the hospital, it's actually a regulatory law and a policy that we ask date of birth. So that's the first thing. And then for the last bullet about don't forget about the family members, many times we walk into a room and there's someone else sitting there and you say, oh, is this your mother? But it's actually, no, it's my wife. Imagine how awkward that is. I don't know, Baxi-Hung, if you have a way of asking, but what I usually do, because I have made that mistake more than once, so now when I see many people or someone else in the room, then I just say, what is everyone's relationship? And then they say, oh, this is my wife. So I don't make any assumptions that, oh, is this your mother? So.
Yeah. Yeah, I used to make that mistake as a medical student. I always ask them like, so who do we have with, us today in the room? And they tell me their relationship.
Mm-hmm.
Yeah.
Because you've made that mistake too.
Yep. Not the, mom or parents, it's brother and sister. So,
oh, is this your brother?
Yeah, is it your girlfriend? No, I'm like, no, that's my brother. I'm like, okay. Yeah, like, that's awkward. Yeah.
Yeah. Oh, is this your father? No, it is my husband.
Yeah.
Okay. So let me, if you could stop sharing for just a moment, or well, I didn't want to take that away. Anyone else have any questions, comments on what we're doing? Okay, terrific. All right, I'm going to share. So today we will be breaking up into rooms. And as Baxi said, the TAs will be doing a small assessment, and they'll be giving you some feedback. Okay, let me share my screen so that you remember how to get into the rooms. Let's see. All right. So just as a friendly reminder, to get into the rooms, you hit the breakout room. And if you want to leave the breakout room, you say leave room and you'll go back to the main page. And then also as a reminder, these are the room assignments for today. And it's the start of summer vacation for the students in the US. So we have several people on vacation. So you might be in a new room with a new TA. So it will be a great opportunity to practice with someone new. I'm not sure if every TA is present yet, but the room should be open.
Helen was in some of the breakout rooms. We do have some feedback for you guys. I know that it's really difficult with the OSCE because there's a lot of new, information, a lot of new things that not necessarily that you guys are doing it in Vietnam, but here in the United States, we do it very often, and we are expected to do it on a consistent basis. So the very first thing is the social history. So I think a lot of you guys are not asking enough about social history. So in the United States, it doesn't matter what the chief complaint is. The minimum that we want to ask about all the patients is at least about alcohol, smoking, drug use, and I think occupation is very important also. So I mean, maybe in your daily practice, I think you should start asking these questions. I know it sounds strange to a lot of the patients in Vietnam, but unless you do it, you're not going to remember. So at least minimum ask them about alcohol and smoking, because I think that will be relevant for anyone, even in the United States or even in Vietnam. And the occupation, again, because the reason is, if a person is homeless and they have no way of paying for the medication, that would change everything. So you need to know if the patient is making at least, an income or not, right? So it's important. And sometimes you need to ask them about traveling, or, is there anyone that's sick around? So those are sort of, more advanced things that you ask them, depends on what their chief complaint is. But the minimum, at least, I think the 4 things that you need to ask anyone in Vietnam, even here or Vietnam, is at least alcohol, smoking, the drug use, and occupation. And then we'll talk about the drug use, because I think that's not something that we ask the patient in Vietnam a lot. So I think the important is how to ask about drug. So in the United States, there's different type of drug use that we ask. Depends on what kind of like chief complaint is. But in general, we break them into different type of drugs. So the first thing that we ask patient is IV drug use. So when you say IV drug use, it's usually a drug that have to be injected through the IV. So for example, is cocaine, heroin. It can be other things too, but those are the big ones. And then recreational drugs. So what is a recreational drug? So this is the drug that it's not necessary that people use it, on a consistent basis because they're addicted to it. It could be that too, but mainly some people use it to enhance their pleasure, right? If they go to a party and they want to be like the other their peers, they use recreational drugs. So those typical are like marijuana, the weed. Some people inhale, gases, magic mushrooms. They give you hallucination, ecstasy. So those are the one that enhance their pleasure and social experience. And the other substance abuse that we always are very aware of our patient is opioids and benzo for like older folks. Obviously they don't know that they are addicted to benzo, but they are using it every day on a consistent basis, and they can have withdrawal from these symptoms. So you need to know about them. So like I want to ask you guys, so how do you guys ask patient about drug use in Vietnam? Like, does anyone want to give an example? How do you ask your patient in Vietnam?
Mấy em hỏi bằng tiếng Việt cũng được. Tiếng Việt có khi nào hỏi bệnh nhân về sử dụng thuốc gây nghiện không? Mấy em hỏi sao? Coi xem còn không. Có phải chắc là không phải hỏi ha, chờ xuống không?
Dạ có thầy. Thế ơi, bình thường ở Việt Nam ấy, bọn em muốn hỏi gì bọn em có hỏi trực tiếp thôi ạ. Thì tức là giả sử như là có sử dụng bất cứ cái loại dạng chất gây nghiện nào hay không, hoặc là bọn em hỏi trực tiếp thôi ạ, nhưng mà hỏi trong cái không gian kín và đảm bảo cái tính riêng tư cho bệnh nhân.
Rồi. Và thường là bất cứ ai của mình cũng hỏi hết, hay là một số đối tượng nào đó mình nghĩ có vấn đề mình mới hỏi thôi?
Thường thì em nghĩ là trong một số cái chuyên ngành đặc biệt thì họ sẽ hỏi thường xuyên, còn lại thì sẽ không phải là cái câu hỏi mà gọi là common question đâu ạ. Tức là ví dụ trong chuyên ngành của em thì em thường không có hỏi câu đấy ạ. Hoặc là nếu mà em không có cái vấn đề gì nghi ngờ á thì em sẽ không hỏi ạ.
Mình thường là mình hỏi là khi mà bệnh nhập viện, chứ mình cũng ít khi hỏi ở trong bệnh phòng khám ha.
Nếu mà nghi ngờ thì mình sẽ hỏi trong phòng khám, còn lại thì nhập viện thì thường là sẽ hỏi ạ.
Ok, rồi cảm ơn.
Yeah. Thì anh muốn hỏi thử ở bên Việt Nam á, là thường thường mình hỏi về giống như thuốc gây nghiện á, thì mình chỉ hỏi về giống như là chích, hay là giống như là có những cái loại thuốc mà bệnh nhân có thể bị nghiện mà mình không biết, giống như là opioid hay là các cái thuốc giảm đau rồi á.
Thật ra thì em cũng không làm trong cái chuyên ngành đấy, tuy nhiên thì hồi xưa em có đi trực ở chuyên ngành tâm thần á, thì tất cả các loại dạng chất gây nghiện thì đều được hỏi hết, bao gồm đường trích, đường hít hoặc là các sử dụng các dạng thuốc viên, thì bên chuyên ngành sức khỏe tâm thần họ có hỏi hết đấy ạ. Em cũng không biết là trong lớp mình có bác sĩ nào chuyên ngành tâm thần ở Việt Nam không ạ?
Em không phải là khoa tâm thần, cũng không phải bác sĩ người lớn, em là bác sĩ nhi. Thì với trẻ em ấy, thì hay gặp trong tình trạng ngộ độc ấy, phải phân biệt với lại có ngộ độc những chất gây nghiện hay không, hay là những chất kiểu như là ma túy đá vân vân ạ, thì sẽ thường hỏi bố mẹ các cháu lúc đấy, nếu mà có nghi ngờ với một cái trạng thái cấp cứu về thần kinh ạ, mà nghi ngờ do độc chất. Còn bình thường ít khi gặp lắm. Còn trong tâm bệnh thì chắc là cũng không phải là thường xuyên đâu ạ, chỉ khi nào nghi ngờ thì mới hỏi thôi.
Ví dụ như mình gặp một bệnh nhân mà khoảng 20 tuổi hay là 25 tuổi, những cái giới trẻ bây giờ á, thì mình có bao giờ mình hỏi ví dụ như là người ta có hút giống như là cannabis hay marijuana hay là weed không? Thì mình nghĩ thì ở Việt Nam hay ở đây cũng có rất là nhiều bạn hút mấy cái đó.
Thi thoảng thì em cũng có bệnh nhân nội ở phòng khám cấp cứu ấy, thì em không hỏi thôi ạ. Nếu mà em khám không hỏi, còn không biết các bác sĩ khác thì như thế nào.
Không có chính sách, không có rầy rài ấy ha. Cái này là cái tùy cái hoàn cảnh với là tùy cái thói quen, tùy cái văn hóa của mình nữa. Nhưng mà chỉ để mấy bạn để ý thôi. Bên đây thì mình hỏi đủ hết, ngay cả bệnh của mình chẳng hạn, mà bệnh nhân vô phòng khám định kỳ, mấy ông bà già của mình thì mình vẫn hỏi, không có hỏi hết tất cả mọi cái, nhưng mà ít ra cũng hỏi uống rượu không, thuốc không, có dùng thuốc gây nghiện, heroin, cocaine, injections. Just the routine question, ask everybody. Of course, if patients come in with suspicion, we're gonna drill further down. But nhưng mà nếu mà có ai bình thường thì chỉ là cái quy trình mình hỏi để mình không miss cái nào hết. Thì cái cách bên này là như vậy, thì ít ra mấy bạn biết, rồi trong thực hành thì khi mình biết thì mình mới để ý nhiều hơn.
Mà thật ra thì tại vì ở bên Mỹ thì marijuana legal rồi, nên là mọi người sử dụng thường xuyên hơn. Còn ở Việt Nam là cần sa vẫn là chất cấm, nên là cái tỷ lệ người sử dụng nó cũng sẽ ít hơn. Nên là cái em nghĩ là cái số lượng cái return of investment không có lớn để hỏi mấy câu hỏi đó.
Có khi hỏi người ta cũng không trả lời.
Đúng rồi, em xin bổ sung một xíu ấy, bởi vì kinh nghiệm của em, tức là em cũng có làm bên trong chỗ giảng dạy và em cũng đi qua rất nhiều các bệnh viện nữa, bệnh viện thực hành lâm sàng, thì nó có hai vấn đề. Một là cái prevalence của nó rất là ít, cho nên mà cũng nó không phải là cái thường quy để thực hành trong bệnh viện. Với hai nữa là cái văn hóa nữa. Một là cái cách hỏi, hai là cái văn hóa nữa. Rất là nhiều người về Việt Nam, tức là người ta nghe đến những cái đấy, người ta nghĩ đến một kiểu rất là xấu, cho nên khi mà bác sĩ hỏi như vậy thì thường người ta sẽ nghĩ là ông nghi ngờ tôi hả. Cho nên mà chỉ khi nào những bệnh nhân ở trong phòng cấp cứu hoặc là những đối tượng đặc biệt, chẳng hạn như là khu truyền nhiễm, mà bệnh nhân HIV chẳng hạn, hoặc là những bệnh nhân vào trong phòng cấp cứu mà có biểu hiện của dùng các chất kích thích, thì các bác sĩ mới hỏi. Còn thực hành lâm sàng thì không hỏi, vì hai lý do. Một là tỷ lệ rất là ít, hai nữa là người Việt khi mà bị hỏi những câu hỏi đấy thì thường có tâm lý phòng vệ, phản ứng và nghĩ đấy là cái câu hỏi đấy nó không phù hợp. Nó liên quan đến thực hành lâm sàng và văn hóa nữa.
Hưng, còn mấy slide nữa không? I wanted to keep it general on the
Okay. So I think, I mean, I guess it's a different culture. So, but if it's going to practice in the United States, then I think that you have to start asking those questions because, all the attendants were expected you to ask those questions. So I think for the simplicity, if you stay in Vietnam, I guess those are the questions that you're probably not going to ask. But here, definitely, it's a must. So the next thing is the closing part. I think a lot of you guys are not asking the closing questions. I think in Vietnam we're not used to ask about the patient. If we miss anything that the patient want to add, it's kind of like a space where the patient can add more, or if they forget something, they can add to it at the end, right? Or if they have concerns, let's say someone in the family have cancer and they really concerned about it and they worry that this headache is, another sign of cancer or something. And those are the times when you ask the patient, what are you most concerned about, this headache? And obviously, they tell you what their concern is, and for you to sort of address that concern on the spot, which is a nice thing. And then also sometimes patients know what causing the symptoms. Sometimes it's a strange question to ask, but a lot of times you actually get some, valuable information out of it. So, for example, someone, come in with abdominal pain, like a female, and you ask them, what do you think this might be the cause? Someone might say, I'm afraid I'm pregnant, like if you don't ask that questions, you're probably not gonna, expect that, they probably are pregnant. So I think that's a valid concern and valuable information. So those are the questions that I think that we need to practice a little bit more. It's just basically at the end of the visit, it's give the patient a time and space so they can add more questions or anything that we miss during the visit. So I think those are the things that we need to practice a little bit more.
All right, Helen.
Anything else? So I wanted to use this opportunity when we're all together to ask the TAs, do you all concur with these recommendations or this feedback? Could someone talk about some strengths that you saw in your groups? TAs, any thematic strengths or thematic opportunities for improvement? Anybody? Nancy, Amy, you guys always have something to say. Calling you out. Okay, Amy.
I'll go first. I had a group of about 6 people, and what I noticed that every single time that we did a case scenario, they catered their questions specific and old cards specifically for their the type of pain or cough they have. So for example, if it was a cough, they didn't really go through old cards. They asked about more of the environment, which I really like, and talking about like how often they cough and the frequency of it.
Okay, terrific. Anyone else have other thematic strengths or opportunities for improvement that you saw in your groups? So I went around and I liked how people volunteered very willingly. And don't think I didn't notice, but you would volunteer early because you knew the questions were easier. Anything else? I can't tell. People have their hands up. Stacy, you have any thoughts?
I think everyone hit the question, especially for the OSCE, they hit a lot of the questions that were on the chart. A lot of my students also expressed a lot of empathy, which I didn't expect. They would say like, oh, I'm sorry to hear that. Like, we're going to help you out. Like, I thought that was really cool. And finally, I guess one criticism I could say is like, everyone missed the occupation question. Like, what do they do for a living? So that's just one area of improvement.
Mm-hmm. Okay. Philong, any themes you saw?
Oh, yeah, I think the feedback that you guys put on were really dead on. It was really great. I think a lot of it's like sort of like culturally different too. Not a lot my doctor was asking about like, I don't know, like the environment the patient were in, like are they in an environment where the adult in the house are like smoking or that sort of stuff. But yeah, and then also the occupation was really good. Not a lot of my my group member was asking about occupation, but they were really great at like diagnosing like the specific problem. I think Amy was talking about, they like cater the entire question, like the questionnaire to asking like specifying, like if I say I have like I'm coughing a lot, they're like, oh, do you have like history with like asthma in your family or something like that, or that sort of stuff. So yeah, that's really great. I appreciate that.
Meng Dong, you're pretty far along in your medical school training. Any thoughts on your own personal training and interacting with patients?
Yeah, I would say I'm so impressed by my group. Like everyone used beautifully a combination of open-ended and closed-ended questions. Like they always ask like what other associated symptoms, and then they will go to the red flags. I'm very impressed. That's important. And also I feel like when time allows, they did make an effort to show empathy to patients, which is important. I think that's really precious, especially, you know, for practicing Asia. And I understand there's always this time limitation there. I guess one area to improve is like I think some of you already mentioned, like asking when you close, like always remember to ask anything else just in case patient forgets something, which is common. I think that's something maybe new to practice in Vietnam, something to get used to.
Terrific, thank you. Milin, I forget like what year in training you are. Do you have any thoughts on your personal
I'm
training?
a third year.
Okay, terrific.
Yeah, my group did really well in terms of following the format for old cards. I think everyone asked very thorough questions about the symptoms I had. And they also did, surprisingly, I don't know if this is taught in medical school in Vietnam. My group had 4 medical students in Vietnam, and all of them did a little summary at the end. Like, so this is what you told me. You had abdominal pain and that comes and goes and all that. And it was like, wow, very impressive. And then they ended up with, did we miss anything? And I thought that was very thorough. It sounds like the students really listened to what I said. And I think one opportunity for improvement could be expressing more empathy. I shared with some of the student that my family member had cancer or my family member had a stroke. And I think it would have been nice if they could have expressed more empathy, like, oh, I'm sorry to hear that, or ask a little bit more about that. I think most of the students went ahead and ask the next question. So it does at some point felt more like a checklist of things they were going through rather than a conversation with an actual person. So I think that's something that I'm sure is like cultural and could be improved upon.
Okay, terrific. Nancy, you're on rotation. What do you think about the patient interaction?
Yeah, my group was really strong.
You had a big group.
Yeah, I had a really big group. But they were very focused on the patient. They listened. I felt very listened to. I felt heard. They were very compassionate. One area of improvement, I would say, is probably not to focus too much on the chief complaint and maybe branch out just a little bit with the associated symptoms and other questions like that, and environmental, asking about the patient's like occupation and any environmental causes that could exacerbate the
what did someone say that made you feel heard or made you feel good?
Oh yeah, I forgot the exact scenario, but I shared yeah, I wasn't feeling great. I was like very much in pain, and they were like, "Oh, I'm very sorry to hear that. You do sound like you're very much in pain. We're here to help." And I was like, "Oh, wow, okay."
So they reflected what you said. So they
yeah.
Right? Oh, okay. That's good. Okay, sounds great. Sang, you were in a very small group. Did you feel heard?
Oh yeah, absolutely. My group members and learners did a great job of empathizing, covering their bases, and also making space for the pretend patient. And I think one thing I'll just say for everyone, honestly, even physicians in the US that I've seen on rotations, one thing to keep in mind is just you're kind of knowing when to especially with chatty patients, knowing how to navigate like getting what you need, making space, empathizing without letting it take, like an hour of your time. But then also with some patients, knowing when to step back and letting them talk, just letting them go. And I think that's a difficult point for really everyone at every stage in their career. I've seen it all the time. And I think my group members did a great job of just knowing when to, cover their bases, not focusing too much on the what they had to ask and making space.
Sang, could you explain what covering your bases means? Because I think that's a phrase that.
Yeah, when I say covering bases or covering your base, or I really mean just making sure you get everything in your checklist, your mental checklist. So here for the OSCE review, we had an actual checklist. So covering your base would mean just mentally going through and making sure you get every single point. So that's what it means.
So as a student, before you go into your exam, before you go into an OSCE, does your teacher, your professors, do they give you the checklist before you go in, or you just have to know that?
We just have to know it. And I think over time, my experience, people start, creating their own illness narrative, which means just mental checklists for kind of cases like chest pain. Everyone always wants to ask, you always want to ask associated symptoms associated with chest pain. So that's what I mean, just a mental checklist, just to cover your bases, make sure you don't miss anything important.
So as a student, that's what you would do together. You would create your own list because you've been examined many times. You've had many OSCEs.
Mm-hmm.
Okay. Yeah. Okay, sounds great. Does anyone else have any questions? Otherwise, we'll break out into our TA groups. Okay.